Hey there, my dear viewers and listeners, and welcome back to my channel. My name is Dr. Nath Arwa. I'm a clinical pharmacist by profession, and I am the founder of Progressive Pharmacotherapy Consultants, your virtual clinical pharmacy institute with a difference, where patient safety, medication, therapy management, and optimal clinical outcomes of pharmacotherapy are crucial and non-negotiable to us. We seek to remain your premier source of tips for high-impact pharmacotherapy services. Welcome to today's video. Now, in this session, I'll take you through a series of patient cases. So in our first case, patient AJO, a 60-year-old woman, is admitted to your hospital from a nursing home for the management of pneumonia. Samples of both her sputum and blood cultures are currently growing non-lactose fermenting gram-negative rods. Now, her past medical history is significant for multiple COPD exacerbations, which have merited admission to your hospital for treatment. And in this case, you're using antibiotics and corticosteroids. Now, on probing her, you get to know that she claims to have sulfur allergies. When you probe further, she informs you that she developed hives on taking sulfur-containing compounds. So, my first question to you would be, what is the most likely pathogen cultured by the reporting lab? Is it E. cloacae, or B. E. coli, or C. Klebsiella pneumoniae, or finally D. Pseudomonas aeruginosa? So I'll give you a few seconds to make a decision before displaying the answer that I feel is correct. So, in my opinion, I feel from that description, Pseudomonas aeruginosa suits the description best. Now, Pseudomonas aeruginosa is the only non-lactose fermenter from that list. It's the only non-lactose fermenter gram-negative rod. Now, Enterobacter, E. coli, and Klebsiella are all lactose fermenters. Now that leaves us with Pseudomonas as the only correct option. Now this lady appears to have a history of hospitalization. Now Pseudomonas aeruginosa is commonly associated with frequent hospitalizations. Now these factors make her the best choice. So D is our correct answer in this case. Question number 2 refers to a patient JPO, who is a 30-year-old male who is hospitalized for the management of infective endocarditis. Now, after culturing his blood samples, catalase gram-positive cocci are grown in clusters. Underline the word clusters. Now, his past medical history is significant for injection IV drug use And on probing about his social history, you get to establish that he's a smoker and he abuses alcohol. Now, on probing further, he tells you he has allergy to penicillins, and when he last took penicillins, there was anaphylaxis. Now the question is, what is the most likely causative pathogen basing on the culture results? Is it E. faecalis? Is it Staph aureus? Is it Streptococcus epidermidis? Or is it S. salivarius? I'll give you 10 seconds to make a decision. Now if you need more time than that, feel free to pause the video. My position, and in my opinion, the correct answer is Staph aureus. Now, Staph aureus happens to be catalase, coagulase positive, and gram positive cocci, which can be observed in clusters under a microscope. Now, it's very frequently associated with infective endocarditis, especially in the intravenous drug users or abusers. Now, Enterococcus is a catalase negative and doesn't appear in clusters under a microscope. Strep epidermidis isn't as common as staph in such incidences. Then the last option is a catalase negative gram positive cocci, and it doesn't suit this description. It doesn't group in clusters either. Now, JWW is a 65-year-old male who is admitted to your ICU for the management of community-acquired pneumonia. His past medical history involves a recent episode of influenza, which was successfully managed with oseltamivir 75 milligrams orally twice daily for 5 days. Now, he also has depression or suffers from depression, which remains untreated pharmacologically, and he has heart failure. Now, his blood culture shows no growth at the moment. And JWW is 6 feet 1 inch tall and weighs 210 pounds, quite a heavy guy. Now his renal function appears normal to me. The serum creatinine is 1 milligram per deciliter. So the question is, which of the following would be the best regimen for the management of his pneumonia during this particular hospitalization? Is it ceftriaxone 2 grams IV infusion over 30 minutes once daily? Is it 500 milligrams of azithromycin infused over 1 hour once daily? Or is it ceftriaxone 2 grams IV infused over 30 minutes accompanied by 750 milligrams of levofloxacin infused over 90 minutes once daily? Or is it levofloxacin 750 milligrams infused over 90 minutes once a day? I'll give you 10 seconds to make a decision. So, in my opinion, according to guidelines, the correct answer is C. I would infuse ceftriaxone 2 grams IV over 30 minutes plus levofloxacin 750 milligrams IV over 1.5 hours. Now, we do not use monotherapy in the management of community-acquired pneumonia, especially in the ICU, based on the IDSA guidelines. Now that makes options A, B, and D incorrect, leaving us with C as the best option. After 1 day, his sputum culture begins to grow Staph aureus, but at the moment the sensitivity results are pending. Now, which of the following antibiotic regimens best suits JWW's current treatment? Is it vancomycin 1 gram infused over an hour twice daily? Is it daptomycin 600 milligrams infused once a day? Or is it linezolid 600 milligrams infused over an hour twice daily? Or is it the younger cousin tedizolid 200 milligrams infused over an hour once a day? I'll give you 10 seconds to make a therapeutic decision. So in my opinion, answer C is correct. I would go for linezolid 600 milligrams infused over an hour twice daily. Now, tedizolid would be the wrong choice despite the dose being optimal and correct, and despite it having effective MRSA coverage. That is because it isn't approved by the FDA for the management of pneumonia. Now, daptomycin is the wrong choice because it is inactivated by lung surfactant and would therefore prove ineffective in the treatment of pneumonia despite having effective MRSA coverage. Now, considering JWW's body weight, the vancomycin dose is on the lower side. This would amount to an underdose, and that makes linezolid 600 milligrams infused over an hour twice a day the best option for the management of Staph aureus in the case of JWW. Now, JWW recovers. You've done a good job and thumbs up, and he is discharged on the following medication: carvedilol 3.125 milligrams twice daily orally with an aim of tapering upwards to manage his heart failure; duloxetine 60 milligrams orally once a day, and fluoxetine 40 milligrams orally once a day to manage his untreated depression. And apart from that, he also has furosemide 20 milligrams orally once daily for 14 days, subject to review, and oral linezolid 600 milligrams orally twice a day for a week because of its good bioavailability to manage the infection to the end. Apart from that, there is lisinopril 20 milligrams orally once a day, and pantoprazole 40 milligrams once a day to manage his dyspepsia. Now, an appointment is scheduled at the clinic in your hospital in 14 days' time. So my question to you is, which probable or highly likely drug-drug interaction may occur in JWW's case. So I'll give you 10 seconds to make a decision. So in my opinion, the interaction would be duloxetine, fluoxetine, linezolid-induced serotonin syndrome. Now, we all know that linezolid is a weak monoamine oxidase inhibitor which interacts with all serotonergic agents such as duloxetine and fluoxetine. Now, prescribing it with both of these drugs, which are meant to manage the patient's depression, would likely lead to the accumulation of duloxetine and fluoxetine, which would lead to serotonin syndrome. Now, this is a very significant prescribing error, in my opinion, that calls for your intervention prior to dispensing. It would be a dilemma because this patient requires oral linezolid for the home discharge because of its good bioavailability, and he also needs fluoxetine and duloxetine to manage the depression. But when they are co-administered, the two antidepressants would linger for longer in his serum, and therefore it would be inappropriate to co-administer the three together. Now, in the next question, MEA, a 68-year-old female, is admitted to your hospital for the treatment of pyelonephritis. Her urine analysis is positive for nitrites. Now, her urine and blood cultures are still pending as we speak, and she's had recent episodes of cystitis, which was treated with Bactrim, trimethoprim sulfamethoxazole. Now, she also has hypertension, diabetes mellitus, and dyslipidemia. And currently, she takes lisinopril, metformin, glyburide, and atorvastatin to manage her comorbidities. On probing during the medication use reconciliation, she informs you she's allergic to penicillins, and on probing further, she tells you the last time she took the same, she had diarrhea. So my question to you is, which of the following would be the best empiric regimen for Madam MEA? Is it piperacillin tazobactam 3.375 milligrams infused over 4 hours every 6 hours? Or is it cefepime 2 grams infused over half an hour thrice daily? Or is it ceftriaxone 1 gram infused over 30 minutes once a day? Or you do opt for Bactrim 960 milligrams taken orally twice a day? I'll give you 10 seconds to make a decision. So in my opinion, C is the correct answer. I would infuse ceftriaxone 1 gram over 30 minutes once daily to manage her condition. Now, the presence of nitrates in urine points me to a likelihood of E. coli or Klebsiella pneumoniae or Proteus as being the likely uropathogens which we are dealing with in MEA's case. Now, this makes Bactrim an unsuitable option due to the very high levels of resistance to Bactrim by this kind of uropathogens. So Bactrim isn't suitable for the management of complicated UTIs such as this case. That makes answer D wrong. Now, apart from that, both cefepime and piperacillin tazobactam have pseudomonal coverage. Now, Pseudomonas aeruginosa is not a lactose fermenting microbe. So, this makes them unsuitable choices from an AMS perspective. Yeah, they are too broad. We don't need anti-pseudomonal coverage in the case of MEA, and that leaves me with ceftriaxone monotherapy as the best option as an antimicrobial steward. Now, both her urine and blood cultures happen to grow E. coli, and the lab results are reported as follows: sensitive to meropenem and gentamicin, intermediate to ciprofloxacin and levofloxacin, resistant to Bactrim and ceftriaxone. So, which of the following would be the most appropriate regimen at this time with the kind of labs that have been reported? Is it levofloxacin 750 milligrams infused over 90 minutes once a day? Or is it amikacin 7.5 milligrams diluted in 50 ml of normal saline and infused over half an hour once a day? Or is it ciprofloxacin 400 milligrams infused over an hour twice a day? Or would you opt for 1 gram of meropenem infused over 3 hours every 8 hours? I'll give you 10 seconds to make a rational therapeutic decision. So in my opinion, D would be the correct choice. I would opt for infusing a gram of meropenem over 3 hours, thrice a day. Now, monotherapy using aminoglycosides is not recommended. Now, carbapenems are the drugs of choice when we have an extended spectrum beta-lactamase, like in this case, especially when there is bacteremia involved. We know that we've grown it both in blood and in urine. Now, fluoroquinolones can only be acceptable for UTIs if they are sensitive and not intermediate, like in this case. You'd face a risk of treatment failure. They wouldn't be used to treat bacteremia in a case where the lab reports intermediate susceptibility, and that makes levofloxacin and ciprofloxacin unsuitable choices. Now, 2 weeks after MEA's successful treatment and discharge, she returns to your accident and emergency with foul-smelling, watery diarrhea. Now, your medical resident on duty orders a stool toxin and GDH tests. Now, both of them turn positive according to your lab, and she's diagnosed with C. diff-associated diarrhea or infection. Her vitals include a temperature of 38 degrees Celsius. Her WBC is 14,000 cells per mm cubed, and her serum creatinine is 1.2 milligrams per deciliter. So, which of the following regimens would be the best choice for MEA's management at this stage? Would you manage the diarrhea with metronidazole tablets taken thrice daily for 2 weeks? would you opt for 500 milligrams of metronidazole infused over an hour thrice a day, plus oral vancomycin at a dose of 500 milligrams taken every 6 hours, both for 2 weeks? Or would you go for 125 milligrams of vancomycin taken orally 4 times a day for 10 days? Or would you opt for a higher dose of 500 milligrams of vancomycin taken orally 6 hourly for 10 days? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So in my opinion, C is the correct answer. I would suspend 125 milligrams of vancomycin and administer it orally every 6 hours for 10 days. The clinical trials have been conducted over a duration of 10 days and not 14. That's what makes 10 days the correct choice. And that is the recommended dosage according to guidelines for moderate and severe Clostridioides difficile infections, like in the case of MEA. Now, if the infection is severe and complicated, accompanied by features such as shock or ileus, then we would go for the higher dose of 500 milligrams orally 4 times a day for 10 days. We'd even combine it with IV metronidazole for better clinical outcomes. Sorry. Now, metronidazole alone is no longer recommended as first line in the management of C. diff infection. So that makes options A, B, and D wrong choices, and it leaves us with C as the most rational therapeutic decision. Now, in the next question or case, SBK is a 32-year-old male patient who has been diagnosed with active pulmonary tuberculosis. Now, SBK's pulmonologist prescribes isoniazid, pyrazinamide, ethambutol, and rifampicin for 60 days, followed by isoniazid and rifampicin co-formulated once a day for the next 120 days. So your pharmacist dispenses the same and does thorough medication use counseling. Now, 30 days into his treatment, SBK calls the pharmacy complaining of decreased visual acuity and expresses an inability to distinguish color red from color green. What would be happening to your dear SBK? Is it isoniazid-induced retrotubular neuritis? Or is it pyrazinamide-induced optic neuritis? Or is it ethambutol-induced retrotubular neuritis? Or is it rifampicin-induced optic neuritis? I'll give you 10 seconds to choose from one of the 4. The correct answer is C. Now, isoniazid isn't associated with retrotubular neuritis at all, so that makes choice A wrong. Pyrazinamide isn't associated with optic neuritis either, so that makes answer B wrong as well. And answer D, rifampicin, isn't associated with optic neuritis. It causes uveitis, so that makes it wrong as well. And this leaves us with option C as our best choice. In the next case, SAU, a 40-year-old female patient who was involved in a road traffic accident, is admitted to your surgical ICU for exploratory laparotomy. Now, she develops fever, which is unresponsive to piperacillin tazobactam at a dose of 4.5 grams infused over 4 hours, 3 times daily, co-administered with gentamicin at an optimal dose and vancomycin to cover for MRSA. All the three are administered optimally and at recommended doses. Now, she has a CVC in situ and a Foley catheter as well. Her blood cultures are pending, but she has yeast growing in both her sputum and urine samples. Currently, her WBC is 12 times 10 power 3 per mm cubed. So the question is, which of the following would be the best empiric antibiotic or antimicrobial agent for SAU? Is it doripenem, administered at 500 milligrams IV TDS? Is it flucytosine? Is it liposomal amphotericin B? Or would you opt for micafungin, 100 milligrams once a day? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So I think in this case I would opt for the echinocandin micafungin. Now, echinocandins like micafungin and caspofungin and anidulafungin are the drugs of choice for yeast infections like this one. Now, flucytosine would be the wrong answer. B would be the wrong answer because we don't encourage monotherapy using flucytosine in such cases. Now, doripenem, being a carbapenem, an antibiotic, can't treat yeast infection, so that makes it a wrong option. And lastly, C, liposomal amphotericin B, is highly nephrotoxic, and in the presence of safer antifungals, I would recommend avoiding it. So that makes answer D a better option than answer C. So after 7 days, SAU is transferred from your surgical ICU to the medical ward. She's making good progress and her lab results are normalizing. Now her blood cultures are growing Candida albicans. So at the moment, which of the following would be the next best course of action? Would you continue the previous therapy? Would you switch to fluconazole? Would you discontinue antifungal therapy altogether? Or would you switch to liposomal amphotericin B infused over 2 to 4 hours? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So in my opinion, B is the correct answer. I would consider switching from micafungin and echinocandin to fungal azole, antifungal azole, fluconazole. Now it's reasonable and more cost effective to make this switch, and discontinuing therapy at this stage is not wise. We should only do discontinuation after we have had a negative culture and treated the fungal infection for 14 good days. And that 14 should be counted from the first day after the culture turns negative. That is in line with the IDSA guidelines. Now, we should avoid amphotericin B in this case. Yeah, it would cause nephrotoxicity. Now, switching to fluconazole, to which most strains of Candida albicans are susceptible, would be a reasonable choice, because this would facilitate SA-use discharge. Remember, the oral fluconazole has a high bioavailability, so that would make option B superior to the others. Now, in the next case, JKL, an 18-and-a-half-year-old female university student, recently returned from a holiday trip in Mexico, Acapulco. 2.5 days after returning from Mexico, she reports to a clinic with a 1-day history of painful urination and vaginal itching. She also reports having many painful lesions on her genitals, but denies having ever experienced such lesions before. So this is the first episode underlying that. Now, the clinician on duty suspects herpes, and he sends a vaginal swab of JKL's vaginal ulcers for culture. So, which of the following is the best regimen for JKL's herpes infection? Would it be valaciclovir 1 gram taken orally twice a day for 3 days? Would it be acyclovir 200 milligrams taken orally thrice daily for a week? Would it be acyclovir at a higher dose of 400 milligrams taken thrice daily orally for a week? Or would you settle for famaciclovir 250 milligrams taken every 12 hours for a shorter duration of 5 days? So I'll give you 10 seconds to make a rational decision. So I would personally prefer acyclovir 400 milligrams taken orally thrice daily for a week. Remember, this is her first episode of herpes simplex infection, so she lacks immunity to the same. Therefore, the duration of therapy and the dose should be longer and higher respectively. Now, in subsequent episodes of the same, we could treat her for a shorter duration, since the goal in that case would be decreasing viral shedding and not treating as such. And that makes option C the best alternative, or the regimen of choice in this particular case. Now, in the next case, an African American man by the name JGM and his wife and daughter are planning an outdoor safari to southern part of Africa. Now, the trio plans to spend 3 days in Johannesburg, 3 days in Kruger National Park, both of which are in South Africa, and they'll cross over the border and spend 3 days in Victoria Falls and 3 days in Plungu in Zambia. Now, JGM currently takes no medication, according to the medication reconciliation you've done. Although recently discontinued fluoxetine, so part of it still lingers in his bloodstream, remember? Now, he tells you or informs you he was taking it for his depression, and his spouse is healthy but 16 weeks pregnant. Now, their daughter, an 8-year-old, is a bouncing girl, healthy. So, which of the following would be the best choice for malaria prophylaxis for Mr. JGM? I'll give you 10 seconds to make an appropriate choice for him. So, in my opinion, I would prescribe atovaquone, proguanil, also called malanil, for JGM. Now, chloroquine wouldn't be an optimal choice due to very high levels of resistance to Plasmodium. Now, doxycycline, which is option D, wouldn't be ideal either because they spend quite some time in the sun and there's a high risk of photosensitivity reactions when basking in the bright African sun during the safari. Now, since JGM recently discontinued fluoxetine, which still lingers in his serum, there would be a high risk of a drug-drug interaction with mefloquine or mefloquine, which could pose cardiovascular risks. Therefore, A would be a wrong choice, and that makes choice C the best option for Mr. JGM. Now, in the next question, I would like to know from you, which of the following would be the best pharmacotherapeutic choice for his spouse for the prophylaxis of malaria during their safari? Is it mefloquine, or would it be chloroquine, or would you prescribe atovaquone proguanil for her, or would you settle for doxycycline 100 milligrams orally twice a day? I'll give you 10 seconds to make a wise decision. So, I would tend to be biased towards mefloquine. Now, mefloquine has the best safety data in pregnancy among the 4 choices listed, and it is effective. Now, doxycycline is contraindicated in pregnancy, and in addition to that, because they'll spend some time in the sun, photosensitivity would be an issue during the safari. Now, chloroquine wouldn't be ideal because of the high levels of resistance, and due to the pregnancy, atovaquone proguanil wouldn't be as safe as mefloquine. That leaves me with option A as the best choice for this pregnant spouse of JGM. Now, which of the following would be the best prophylactic options for their 8-year-old daughter? Would it be mefloquine taken daily? Would it be chloroquine taken once a week? Would it be atovaquone proguanil taken once a day orally? Or would it be 100 milligrams doxycycline taken once a week? I'll give you 10 seconds to make a decision. So I would opt for atovaquone proguanil taken daily. Now, mefloquine should be taken prophylactically once weekly and not daily like in option A. So this makes A the wrong choice. Atovaquone proguanil, however, is given daily, and it should commence 1 to 2 days before departure. It should be taken during their stay there and prolonged for a week after returning to their home. Now, though chloroquine may be used prophylactically once weekly, it isn't a suitable choice in this case due to high levels of resistance. So that makes choice B wrong. And because of the age, 8 years, doxycycline would not be an ideal choice for malaria prophylaxis. So that makes option D unsuitable. Now, I would like to remind you of the fact that mefloquine should be initiated 2 weeks before departure and should be administered once weekly and continued throughout the trip, and it should be prolonged for another 4 weeks after returning. Of course, remember it's a weekly and not a daily dose. So, my dear listeners, I appreciate your attention. And I thank you very much for listening. I hope these bits and pieces of information help you manage your patients in a better way. Now, if this video benefited you in any way, I would like to urge you to subscribe to my channel, to share it with your fellow professionals, and to like the channel. I wish you safe and effective pharmacotherapy with optimal clinical outcomes as you practice your clinical pharmacy. Thank you all.